Good afternoon, everyone, and welcome to SAMHSA's Gang Center. Today we are presenting a webinar on the APIC model. We are presenting on the best practices in reentry, the assess, plan, identify, and coordinate model. So I am Melissa Neal, a Senior Research Associate at Policy Research Associates, and we run SAMHSA's Gang Center. And I just have a few housekeeping remarks. First, the views, opinions, and in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. So throughout the presentations, we welcome your questions. You will see a Q&A pod to the lower right of your screen. And we welcome you at any time throughout any of the presentations. Submit your questions, and at the conclusion of the last presentation, we will have some time to go through all of the questions submitted. We also have a couple of polls that will be going on, and we really encourage your participation. As you may see on the right side of your screen, we have the first poll has already popped up, and we would really appreciate your participation in that. And finally, please note that this webinar is being recorded. So we have a great agenda for you today. We'll start with some opening remarks from SAMHSA, and then we'll move into a presentation about the APIC model if you're not familiar with it yet. And then we'll have presentations from two local sites who will describe how they're using components of the APIC model in their reentry programming. And as I said before, we'll conclude with some time for question and answer. So first, I'm going to turn it over to Andrea Harris for some opening remarks from SAMHSA. Andrea?
Oh, good afternoon, everybody. I'm really excited about today's webinar. As many of you know, returning to the community after incarceration is not often a very easy process for people, especially people that have a mental or substance use disorder. So I think this model really provides a framework for criminal justice and behavioral health systems to be able to best address the needs of people returning to their communities. So on behalf of the Substance Abuse and Mental Health Services Administration and the Center for Substance Abuse Treatment, I'd like to welcome you to today's webinar.
Thank you, Andrea. And now we're going to take a few minutes just to introduce you to our presenters today. First, we're really excited to start with one of our own from Policy Research Associates. Travis Parker is a Senior Project Associate 2 in the Criminal Justice Division at Policy Research Associates. And some of you may have met him in many of the training and technical assistance workshops that we provide across the country, including the sequential intercept modeling mapping that we do. Previously, he served as the Vice President of Systems Transformation, Tribal Liaison, and Director of Clinical Services at Magellan Behavioral Health of Nebraska. He's also served as the Deputy Director of the Community Mental Health Center of Lancaster County, Nebraska, and Program Director for the Behavioral Health Jail Diversion Program in the Emergency Services, Homeless, and Special Needs Departments at CMH-CLC. Ross Butendorf currently serves as the Director of Network Services for Behavioral Health Services for Network 180, which is the Community Mental Health Center for Kent County, Michigan. Previously, he has worked in the behavioral health field for 25 years. Previously was appointed by the governor to serve on the state of Michigan's Mental Health Diversion Council. And he's been involved in many reentry service expansions, grant programs, including introducing medication-assisted treatment in the Kent County Jail. Sally Johnson Van Wright is a 25-year veteran of the Hampden County Sheriff's Department, and in this role, she has designed and delivered gender-responsive programs for women and men, both in custody and post-release, and she incorporates a trauma-informed empowerment approach. And she specializes in criminogenic risk reduction and stabilization through cognitive behavioral change strategies. She teaches practice, research, policy, and human behavior at the Springfield College MSW program as an adjunct professor. And Martha Lyman is a research director at the Hampden County Sheriff's Department. And in this role, she developed an integrated network of data sources to support the ongoing study of recidivism, program evaluations, and offender assessment in a way that was unprecedented in county corrections. She is the co-founder of the Massachusetts Criminal Justice Agency's research group, and she coordinates the Hampden County Regional Reentry Task Force and the Hampden County Addiction Task Force. In the past, she's served on the staff of Massachusetts Governor's Commission on Corrections Reform, the Urban Institute Jail Reentry Roundtable, and Massachusetts Pew Results First and Justice Reinvestment Initiatives. So we are excited to have a tremendous panel of experts here to present for you today. And for now, I'm going to turn it over to Travis Parker.
Thank you very much, Melissa. I appreciate the introductions of all of us. Welcome to everyone. It looks like we have a large group that has joined us today. Again, my name is Travis Parker with Policy Research Associates, and I have the honor today of talking to you a little bit about who our population of focus is for this particular webinar, focused on transition planning and reentry from the justice system back into our home communities, as well as providing an overview of the APIC model that Melissa introduced: assess, plan, identify, and coordinate. I realize in many instances today we will be preaching to the choir, so it's great to be amongst like-minded individuals, and we welcome all of your questions throughout the day today. As Melissa talked about early on, we had a poll that we wanted to get a better idea of who you are with us today, and we'll be taking a look at who some of you are, what disciplines that you come from. And you can see, hopefully on the right-hand side of your screen, that it looks like we have a large number of you that come from mental health, substance use, corrections, and other categories. A smaller number from law enforcement and family or consumer-operated organizations, and approximately 10% of you working in the courts somewhere. So it's nice to have a broad representation of individuals across the criminal justice and behavioral health system with us today. Let's talk about very briefly why we're here. The purpose of today's webinar is, as you can see, the distribution of you who are in attendance today, to really talk about some examples. And I'm excited that our colleagues from Kent County, Michigan and Hampden County, Massachusetts will be joining us today to really offer those illustrations of how you implement successful strategies for transitioning people with mental or substance use disorders from an institutional correctional facility back into our home communities. And I really want to stress that. These are persons who are coming back to be our neighbors, our coworkers, folks that we will interact with on a daily basis, which makes that transition and reentry planning very critical to individual success of not recidivating back into the justice system. So who are we talking about? A quick overview here. One of the things that we know is when we look at prevalence rates in the general population that are not about positive things, so for example, cancer, heart disease, serious mental health issues, substance use disorders, and we take those general population prevalence rates and move into the justice system, those prevalence rates tend to get much worse. And so as you can see from this slide, when we look at the general population across the United States, roughly 4% of individuals have a serious mental illness. We're not talking about things like situational anxiety or depression or a sleep disorder. We're talking about schizophrenia, bipolar disorder, PTSD, et cetera. When we move into our local jails in our home communities, that number rises to 17%. So from a public health standpoint, I want you to think about 1 out of every 6 people coming into your local jail facilities have a serious mental health issue. And then when we complicate things even further, 3 out of every 4 of those individuals also have a co-occurring substance use disorder to go along with that serious mental illness. Speaking of substance use disorders, we know from various studies cited at the bottom of this slide that approximately 4 out of every 5 people who are arrested test positive for some substance. And when we look at those who are booked into jail, 63% have tested positive for a substance, with 22% of those individuals having a diagnosable co-occurring disorder and 41% having a diagnosable substance use disorder only. Yet, we only have the treatment capacity and availability to treat 1 out of every 5 people, or 20% of the folks, while they are incarcerated. And it really begs the question as to why we're still looking at our local justice systems as the answers to some of these very complex problems, when we clearly don't have the capacity to provide the treatment needs for individuals in those settings. Another topic that we want to touch on real quickly, in addition to what we commonly think of as mental health and substance use disorders, is the prevalence of trauma in our local justice systems, in our jails and our home communities. At Policy Research Associates, we did a study with 20 jail diversion sites across the country, and 2,122 participants in those jail diversion programs participated in the study, looking at physical and sexual abuse that they experienced. There were 2 things that really surprised us in terms of the outcomes of this study. One was, we expected to see fairly significant differences amongst men and women in terms of the prevalence rates of their trauma, most likely from physical or sexual abuse. And as you'll see from this slide, the gender differences were not significant at all. They were very comparable. The second thing that surprised us coming out of the study was the recency of the trauma that people endured who are coming into these jail diversion programs and into our local jail systems. As you will see on the right-hand side of the slide, roughly 3 out of every 4 women and 8.5 out of every 10 men experienced physical or sexual abuse in the 12 months leading up to the arrest that led to their involvement in these jail diversion programs. And so what this is telling us is that people are not only dealing with significant trauma from many, many years ago in their lives, but as we are coming into contact with them right now in our local justice systems, people are experiencing trauma today. And it's not just trauma, it's significant trauma. So we have very complex issues that we need to tend to when folks are with us in the justice system. As the Pew Center stated in 2011, upon release from jail or prison, many people with mental or substance use disorders continue to lack access to services and too often become enmeshed in a cycle of costly justice system involvement. And I think we could probably say a similar thing today here 8 years later in 2019. Our former president, Hank Stedman, who is now retired, and Bonnie Vesey 22 years ago in one of their publications, really summarized well. Indeed, the least developed jail-based service is transition planning. And what we continue to see 14 years of things like sequential intercept mappings is that this remains a very common gap amongst jurisdictions across the United States 22 years later. And this really is, as you're going to hear me talk about here in a few minutes, it really can be a matter of life and death for people in terms of how well we do at transition planning and reentry planning for people who are coming back into the community. But it remains a significant gap across the United States and our home jurisdictions. There was a study done in 2007 in the New England Journal of Medicine, and then you also see towards the bottom of this slide studies that have continued to look at this through the Bureau of Justice Statistics. In Washington State, a study of 30,000 prisoners really showed that when good reentry planning did not happen, there was a higher incidence of death rates, much higher, 3.5 times higher than that of the general population. And the primary causes of death for this population coming out of the Washington State prison system, the leading cause was drug overdoses, followed by heart disease, homicide, and suicide. Post-release death by suicide was nearly 3 times higher than in-jail deaths. And certainly we, rightfully so, we worry about the safety of people while they are in our jail facilities, especially with things like suicide and homicide. But really what some of the research shows us is we need to be more concerned about what happens to people shortly after their release from our institutional correctional facilities related to drug use, homicide, and suicide. So it's very careful that we're attentive to these issues. When we talk about facility to community transition, the reentry framework that we really want to follow is, and again, realizing that I'm largely preaching to the choir today, is that reentry really does start at the time of being booked into the facility, and that we want to do a good job of sorting the population that's in our facility both by risk and need, while focusing heavily on people who are deemed to be at medium risk, primarily because folks who are low risk may not need as much of our attention, and many high-risk individuals may not be amenable to treatment, but typically those that are medium risk have fairly high treatment needs as well as supervision needs when they come back into the community in order to lead to lower recidivism rates and an increased community tenure while they're back in our jurisdictions. We want to use a validated risk and needs screening tool for criminogenic needs and a checklist, which we're going to talk about here in a minute, for individuals and some of their transitional needs outside of our correctional facilities and what it is that they need when they return home to our communities, especially for individuals with significant mental health, substance use, and trauma histories. And finally, we want to focus on addressing what people need in order to find increased stability in the community within the first few hours of discharge, within 1 week, 3 months, and 9 months. The literature shows that these are critical time periods for people as they are transitioning from facility-based care into the community. And you'll see on the right-hand side various reentry models. What I really want to focus on with the next slide is reach in and the importance of good transition planning following reach in models. I'm not going to read this slide to you, but basically here's what it says. If we give people a card or information as they are getting ready to transition back into the community that says, here's a phone number, call this person or this organization and get some help, versus if we have people who actually come into the facility and say, you know, hi, my name is Travis and I'm going to be the person, or I have a coworker that's going to be seeing you on Tuesday. We're eager to begin working with you and to help you. InReach tends to work much better in terms of the follow-up rates of individuals when they leave facilities and come back into the community. When I was in the managed care field, we always focused on 7-day and 30-day ambulatory follow-up rates after a person left the inpatient hospital setting and came back into the community for community-based services. And this is really where we need to focus our attention as folks are transitioning out of correctional facilities and back into the community, is how do we increase follow-up rates to community-based services, treatments, and support. So with that, I want to begin to touch on the APIC model. Again, as Melissa talked about earlier, the APIC acronym stands for Assess, Plan, Identify, and Coordinate. We want to first assess the person's clinical, social, and public safety needs or risks. We then want to plan for the treatment and services required to address the person's needs. We thirdly want to identify the required community and correctional programs responsible for post-release services so we can make those connections and warm handoffs. And finally, coordinate the transition plan to ensure implementation and avoid gaps in care with community-based services. So while the acronym may seem simple, it's a very heavy lift, and it's important that there's great coordination and collaboration that goes on. There are several publications that have been put out on the APIC model and transition guidelines, the 10 guidelines that we're going to talk about here very briefly in the next few minutes. You see a publication up here entitled The Guidelines for Successful Transition of People with Behavioral Health Disorders from Jail and Prisons. First work done by Alex Blanford and Fred Osher with the Council of State Governments, and revised by Dr. Melissa Neal, who was just on earlier, as well as Dr. Maureen McLeod with Policy Research Associates. So we invite you to definitely take a look at this publication as well as some additional materials that will be available for download after this webinar. When we go out and we do a sequential intercept mapping, one of the things that we always include here, and this is called Intercept 4 when we look at reentry planning of the sequential intercept model, is we have created a reentry checklist called the Gaines Reentry Checklist. And this 10-area reentry checklist is based on the APIC model. It's available in the public domain free of charge to assist jails with good reentry planning for persons with behavioral health needs. It's a quadruplicate form so that the facility, treatment providers, as well as the individual that the reentry planning is focused on all have copies of this, looking at the person's potential needs upon reentry, as well as what steps have been taken to address those needs. And as you will see from this next slide, again, I'm not going to read this to you. You can see the 10 domains that are covered on the Gaines Reentry Checklist. And this is a document that we can also make available to you if your correctional facility has an interest in using the Reentry Checklist. So what is the relationship between the APIC model and the 10 implementation guidelines that are available to view in the publication that I just showed you a couple of slides ago? Really what we do with the 10 guidelines is they break out very nicely into the 4 letters, the APIC, or Assess, Plan, Identify, Coordinate of the APIC model. The first 2 guidelines that appear up on the screen are guidelines or domain areas that fit within the Assess piece of the APIC model. Our first step or guideline is we want to conduct universal screening as early in the booking intake process as feasible and throughout the criminal justice system. And really what this does is it helps us begin to identify what the mental health, the substance use, the housing, the trauma, et cetera, needs are for an individual, not only while they are incarcerated in the jail setting, but also to assist with that reentry or discharge planning back into the community. We want to make sure that this is a standardized instrument that's reliable and valid, and most oftentimes not a homegrown instrument that we use to capture a few areas. The second piece of the Assess part of APIC is for individuals who have positive screens, we want to make sure that we follow up with the next step or a comprehensive assessment after that screening to guide appropriate program placement and service delivery. The next 2 guidelines fit within the P or the plan of the APIC model. So the third guideline is we want to develop individualized treatment and service plans using information obtained from the risk and needs screening and assessment process. So what we begin to do is translate our findings from the screenings, translate our findings from the assessments, and really begin to create a treatment and service plan for that person. The fourth guideline is we want to develop a collaborative response between behavioral health and criminal justice, exactly who we have on this webinar today amongst the almost 400 of you that have dialed in. And we want that collaboration to work together to match the individual's level of risk and behavioral health need with the appropriate levels of supervision and treatment as we begin to plan for reentry of this individual back into the community. The next 2 areas of the APIC, or I'm sorry, of the guidelines, guidelines 5 and 6, fit within the third letter or the third piece of the acronym APIC, and that is identify. We want to begin to anticipate that the periods following release, and you saw this earlier, the 2 hours, the 1 week, the 3 months, the 9 months, that those are critical, and identify appropriate interventions as part of the transition plan for persons with co-occurring mental health and substance use disorders leaving our facilities. And then ultimately develop policies and practices that facilitate this continuity of care through the implementation of these strategies that promote linkages. So we're not just talking about, again, here's a phone number to call or a person you should go see or an agency that you go to. We're talking about developing warm handoffs with people like peer specialists, with system navigators, with case managers and other people who can assist with post-release treatment and supervision strategies. So probation officers, parole officers, et cetera, across the criminal justice and behavioral health system. The last 4 guidelines, guidelines 7 and 8, fit very nicely within the last piece of the APIC acronym, or the coordinate. And that is guideline 7, we want to support the adherence to treatment plans and supervision conditions through these coordinated strategies with criminal justice and behavioral health partnerships. Guideline 8, fitting within the coordinate piece of the APIC acronym, we want to develop those mechanisms to share information from assessments and treatment programs. And what I mean by this is we don't want to continually repeat the administration of screenings and assessments across different components of the criminal justice system. The more that we can share information and not have people retell their stories and re-traumatize them, we produce better outcomes and increased community tenure for individuals. And finally, the last 2 guidelines, guidelines 9 and 10, which again are part of the coordinate piece of the APIC acronym, We want to encourage and support cross-training. And this is true cross-training. This isn't, you know, I work in a correctional facility and I want the local mental health center to come train my staff on mental health symptoms, signs and symptoms. What that means is the local mental health center should also be asking the correctional staff to train their case managers and other people on, you know, what the rules and regulations of the facility are. Why can't I just come visit a person anytime I want to or bring anything into the jail that I want to? So true cross-training across criminal justice and behavioral health systems. And then finally, we want to collect and analyze data to evaluate our program performance, identify gaps, and plan for long-term sustainability. We have to start somewhere. We have to collect baseline data, because if we don't collect data, we don't know if we're making a positive impact on people's lives or even having a detrimental impact where we need to correct our course. And with that, I am now going to turn this over to Ross.
Thank you, Travis. Can everybody hear me? Okay. So I'm going to give, so Travis had the big overview, and I'll let you evaluate how well Kent County does with the APIC model. And so let me give you just a brief overview, because we've got just kind of understand the environment we're in and how this program is funded as well. So currently the Jail Mental Health program is funded through Michigan's Mental Health Diversion Council, which I'm also a member. And it's a pilot program, and we have a number of them through the state. And the council, it was started by Governor Snyder, and now it's being continued with the new administration. And the council is made up of representatives who are from pretty much every area. If you had a serious mental illness or a substance use disorder, you may run into their discipline as you navigate through the law enforcement or criminal justice field. The goal of the council is very simple: to reduce the number of people with mental illness or intellectual or developmental disabilities from entering the criminal justice system. And the goal of the council really is to ensure that we have all counties or all areas in Michigan that have kind of an A+ service within every, all 6 of the sequential intercept model points. And as Travis already walked you through, again, the sequential intercept model, that's what we use as far as guiding where services are, how they're implemented. And when it comes to the Kent County project, we are really focusing on intercepts 2 and 3, and I really should say, and also 4, because there is a reentry component to that. And I'll explain that later on in the presentation. So where's Kent County? Kent County, this is my lowbrow little way to show you. It's western Michigan. We're about 40 minutes from Lake Michigan. Good population, 650,000, and the jail is more an urban jail. So it's we've had as high as, I want to say, 28,000 bookings, and it's been reduced over the last few years, and that's for 2018 we've had 22,000 bookings. So to begin with an overview of what we do in Kent County as far as screening, assessing, referring to treatment. So within the Kent County Jail, it provides all screening and then further assessment for all individuals booked into the jail. Anybody who has a serious mental illness and or a substance use disorder, there are many different treatment options within the jail. We have both a jail mental health pod, and we also have 3 different levels of a substance use disorder service delivery. We also have case management within the jail, and they really focus on reentry coordination, both in and then out of the jail for individuals that are booked. So getting to the A and APIC, the assessment, so we really, the work that we've done in Kent County is really attempting to use kind of multiple redundant systems, if you will, to ensure that we do not miss individuals. So starting from right when a police officer is booking an individual, if that police officer or the booking agent, the correctional officer there, believes that that individual, something's not right, or they suspect something either by something they said or how they're acting, they can flag them and that individual will receive an assessment. That's even before they've received a screening or anything like that. So now, then once they are going through booking, jail medical screens everyone. And we have mental health questions that are in that screening that if they answer affirmative to any one of those questions, they too are referred for additional assessment. And then finally, and I think this is almost one of the most important ones if you're working with your jail to implement something like this or currently have it going, is that anytime somebody's ever been booked into the jail, if they had psychiatric medications, if they were flagged as needing further assessment, or had any issues within the jail, they're flagged, and that flag remains there forever. And so if somebody comes in and the screening misses them and they look just fine, we're still going to do another assessment on that individual because they were flagged as needing more service or more assessment before. And I think that's a really important one because many people are able to hide or they don't want to answer questions honestly. And so it's those three ways that we believe we capture most all of the individuals coming into the jail that we can then provide the appropriate service for them. And I got some additional slides that will kind of show that. So this slide, now upon review, I've kind of screwed it up, so you probably just have to listen to me a little bit. So part of the jail pilot through the Mental Health Diversion Council, we have a research group through Wayne State, and they have us use the K6, the Kessler Screening Scale, and we do that, say, once a year, and then we can compare that to who we're actually capturing for further assessment. So when we did the K6, it identified 22% of the individuals who were coming into the jail needed further assessment. And when we did just the three different methods that I talked to you about previously, it identified 34%. And there were very few positive K6 screens that were missed within that 3 or 4%. So typically in Kent County, we're over-identifying individuals, and I think that's the side right now we want to err on. But that's as far as it, that just kind of shows the results of how that assessing is going. So moving on, the assessment and placement. So of the 22,000 people in fiscal year 18 that came through the jail, 8,000 of them needed an additional assessment by jail mental health staff. The focus, again, is on risk, current connection to mental health and addiction services, and then also they address placement concerns within the jail. So daily, we have jail staff, we have medical staff, and the behavioral health staff meet together to review any new individuals who have a serious mental illness or if there are any current issues with individuals who are in the jail. Again, they're trying to place that individual in the safest place where they can get any appropriate treatment as needed. Jail mental health staff really function effectively as correctional officers, but they're just they're behavioral health staff. So they really are part of the jail. And moving on. So placement, a jail mental health pod. So people assessed with a serious mental illness are placed either in the jail mental health pod or the general general population, and that really depends on that individual's stability at that point in time. And they can be moved in and out if need be. All people with a serious mental illness receive treatment, no matter if they're placed in the jail, no matter where they're placed in the jail. The jail mental health pod is a 64-bed unit within the jail, and correctional officers and mental health professionals, they walk freely within that pod. There's no glass separating them. We're trying to be as trauma-informed as we can within the jail, and treatment is provided daily in the pod. We've also had, and I didn't add this to the slide, the correctional officers have gone through a crisis intervention training, and I believe that's a 1 or 2 day training, which also assists them in better working with the population that we're talking about today. So, in addition to jail mental health services, people assessed having a substance use disorder or co-occurring substance use disorder and mental illness, we provide them information of the different services that are available. There's both men's and women's SUD programming. We have 3 programs currently right now for SUD and co-occurring services, all located in separate pods. 2 pods are for men and 1 is for women. Program staff and the substance use disorder programs really work with individuals to connect them to outside treatment agencies and services at discharge. So all of the services within our substance use disorder programs are operated by outside providers, and they have a direct link. So when somebody is discharged from care here, they will have an appointment already set up. Moving on. And so this is our case manager, their responsibilities here. It's a really important and big job. So on a daily basis, they're checking admissions, they're reviewing screenings and assessments, and making sure that they're catching everybody who has services through Network 180, which we're the community mental health for Kent County, as well as anybody else who's flagged as having a serious mental illness. There is some, not everybody with a serious mental illness necessarily are eligible for CMH services. It's more on level of functioning, and so they would probably be referred to other treatment providers in the community once upon discharge. So once we identify an individual, the case manager identifies an individual within the jail who has a serious mental illness. Then they'll work to determine if they have treatment on the outside. If they do, they will contact the community treatment provider, make sure that they are aware that they are in jail. They will obtain any information, such as prescription information, from the community treatment provider and quickly refer that to jail medical. And again, coordinate with jail medical to make sure that individual continues or gets back on their psychotropic medications. They will do the same thing with a primary care doctor if they're treating somebody who's not in CMH services as well. Once that is accomplished, so then if the individual is going to remain in jail for any period of time, they'll develop a treatment plan with that individual and also reentry plans. Those plans are communicated with the community treatment provider, and the case manager continually updates the community treatment provider, especially attempts to make sure that they're aware of when that person is exiting the jail and that there is an appointment date within 7 days of that individual leaving jail. So again, coordinating that discharge, and they also call 7 days post discharge to make sure that the community treatment provider indeed has met that individual and that they're back in services. So this is kind of getting to the funding model and kind of why things or how things work well in Kent County. So I can't say enough about building a relationship with the Sheriff's Department. We've had a long relationship. Obviously, we don't always see eye to eye because sometimes we have different goals, but I'd say most of our goals are the same. It's really, good care for our community members. Historically, we have split costs with the Sheriff's Department, and that's ebbed and flowed, but that's the way that it's worked. We've both got skin in the game. Even with the grant, there's some, as you know, grants don't always pay for everything or indirect service, and so we continue to split that funding. But the relationship is really important, and it's allowed, I think, a healthy product to be produced. Obviously, we're not perfect here in Kent County. We still have holes, and so here's a few of them. So we've got more community mental health consumers. They're connected post-release to treatment than those who have no previous community mental health relationship. So if they're not eligible for our services, or they have a benefit through the Affordable Care Act, connection is not as good. So we need to examine other linkage options for non-CMH consumers. We also need to examine a solution to provide non-CMH consumers with medications or prescriptions at release to improve continuity of care. The final thing on this is this is a real, the Diversion Council wants to do this as well. And it's establishing a standardized screening tool at booking. So right now we have, we use our own, the sheriff's and ours kind of home-baked, screening instrument. And we'd really like everyone within the state of Michigan to use the K6 or another agreed-upon screening tool. And that way we'll have, those empirically verified measures, and it could really help us best identify who is entering the jails in Michigan. And there are a couple questions too. I heard there's one here that I can answer as far as our mental health services available 7 days a week in the pod. And yes, they are. We've got jail mental health staff work. It's not 24/7. It's 2 shifts a day, 7 days a week. And that's it for me. And I can attempt to answer some of these questions. And I will hand it off to Sally Johnson.
Hello, this is Sally and Marty, and we are delighted to be with you today. Just to put us in context, we are at about the middle zone of the sequential intercept, so we played some part in 2, 3, and 4. And the first thing I'll tell you is a little bit about, I'm figuring out how to advance the slide. Oops, how do we advance? Let's see, I think it's this one. There we go. Nope, other way. So sorry. There we go. So to just give you a little context for Hampden County, we are in western Massachusetts. Today our count is 1,140 at these various sites. And so there's a main institution for men, also for a pre-release for the men. We have a separate center for the women, and then 2 sites that are co-ed, a treatment center, and I'm going to be saying the phrase AISS a number of times, and that is the present name for our After Incarceration Support Systems program. So what we're going to do when Marty and I talk with you this afternoon is that I will be giving more of the kind of program design and some of the themes, and then Marty, who's our researcher with the department, is going to help you understand how the data has been driving our model for quite a long time. The first important concept is that reentry does start at day 1 at Hampden County. So we've said that for some decades now with great appreciation. Some folks might be familiar with our former sheriff, Michael J. Ash. He started us down this road, and with our present sheriff, Sheriff Ash's successor, Sheriff Nick Cochee, we've continued down that road. So when we think of reentry, we believe that a holistic model is the only way to go, and that we have to be thinking of a 3-legged stool. And the 3-legged stool, of course, has got to be helping people think through and make connections for their housing, their employment, and the supported services that they might need. So when you look at what we do as a reentry center, first of all, we've been doing it for quite a long time. I'm actually here with the original manager, Jen Sorty, the original staff. There were 3 at the very beginning in 1996 for the AISS program. From that point forward, we know that reentry has got to start at day 1, and we heard it mentioned about a warm handoff. It has to be that not only the offenders are thinking through their reentry, but they're in relationship with someone. They have a connection with someone and are having dialogue about that. So we started in 96. Initially, we thought we would have to mandate everyone, and then we found out if you can make good connections with folks, they will come whether they're required to or not. And we're actually very proud of the fact that 62% of the people who come through our door on a daily basis at this point, and it's been true for some years, 62% of them have no probation officer, have no parole officer. They're coming through because they think we may have something that will be helpful to them. So that productive and respectful engagement has got to begin before the person gets released and continue once they move out into the community. In 2007, we moved to a new center. 01109 happens to be our highest arrest zip code. It's called Mason Square. And so folks can get there by walking to get there. They can get there on the bus. We're very accessible. We are in the neighborhood where many of the folks that we serve lived. And when we got to that new center, we invited agency partners. And that's a really important part of our formula for success, where we say to agencies, hey, we serve the same people. Let's partner to make that happen. And we brought all kinds of services under one roof. So next, you're going to see what the front door actually looks like. And we are looking at 3 basic goals. And the 3 goals as part of our mission statement are, of course, to reduce recidivism, to improve public safety, and to support the whole person. So last week, as an example, through that opening door, we had 89 people come through on an average each day. It ranged from 52 to our high day was 121, and that's a pretty typical week for us. And we have 612 active cases right now at various levels of service. So to make this a place that people actually feel is useful, we have organized what you could call a one-stop shopping experience. And so AISS is like a hub. And from there, we've got a team of folks who work with employment, and employment has to include everything from employment readiness and getting a universal job application ready and a resume, all the way through interviewing skills to job search. And then, of course, it's actually harder to keep a job than to get a job for many of the folks that we work with, so employment retention is very important. We've pioneered a housing model that has become very successful, and actually we followed after New York State, Connecticut, and Washington State. We do have an MOU with our local housing authorities, and we work with people over time through what we call a changed person file, and help folks who are carefully screened and supported and working towards a service plan towards long-term residential stability, and in some cases, depending on their eligibility and income and so forth, that could involve a project-based voucher or a mobile voucher, or what we call Section 8. And so we engage with those folks over a 3 or 4 year period of time. The stabilization needs are often a short-term engagement, but when folks come out, they may not have the right clothes to wear. They may not, because maybe they were arrested at a different season of the year. They very often do not have identification, and of course you can't get a job or an apartment if you don't have an ID. They might need food. They might need connection to a mental health provider or a continuation of their medication script from when they were behind the wall receiving mental health services. We presently have 56 volunteer mentors, most of whom have lived experience of incarceration, and they're trained and connecting with folks both behind the wall. Again, any given member of our team has usually got one foot behind the wall before people get out and the other foot out in the community helping people continue as they re-enter society. Mass Health we were one of the first states with universal health care, and universal as it is, it's not necessarily easy. So it does take some assistance and maybe some waiting on the line, and there's a local health agency that comes in once a week and helps people get signed up, and supplemental nutrition assistance program comes in to make sure that people can get the food that they need. All kinds of community linkages. So that kind of looking around the person at all the various needs is very important to us. We know that when we start with people, we want to start where the clients are at, and so we're next going to show you some of the things that they ask for. When they come in, they typically ask for those immediate stabilization kinds of needs. They know they got to get things going and get a job and get a place to stay. Interestingly, if you scan that chart on the left, you'll see with all those red bars, substance abuse and support for their recovery usually doesn't appear there. They typically think they don't need help with that. So we start with them where they're at, engage the relationship, provide the support, and then often it's thereafter that the substance abuse counseling, sometimes an intensive outpatient program or even going into residential program, that's going to come a little bit later. We did a study to see how much time tended to elapse before people came in voluntarily to ask us for connection to services, and we landed at about something between 10 and 12 weeks. So it's not uncommon that people show up the very day they get out or the next day, but it's even more common that they go out, try it on their own, and then things aren't working out, and they remember that mentor that they were talking with or that staff that said they would help them out, and then they come on back in and do an intake at AISS. So the leap from an in-custody setting out into the community is certainly not an easy one, and of course the image is a little bit simplistic. There are barriers and challenges that folks are going to face as this happens. But of course the alternative is what they knew, and that typically was toxic, fast money, old relationships that were not healthy, well-known people and places and things that led to the justice involvement in the first place. So we know that this leap that someone needs to make when they get out is really important, and so we try to help bridge that divide. It's important not only for that individual, but for their families, for their communities, and for whoever might have been in their circle of victim impact were they to return to criminal conduct. So, of course, this person in the image looks like he's very propelled from his own internal motivation, and that's a little bit aspirational. In fact, there's often a lot of ambivalence that people have when they come out. So they want to give it a try, but they're still not really quite sure that it could happen. So that's where the relationship and the connection comes in, so that they'll keep coming back to Monday night mentorship or Tuesday night women's group or Wednesday night men's parenting group, things like that. There's not too many places in the country that we know of that have an annual graduation party and have people actually show up. We do that. We'll be having our 23rd one, I believe, this fall. And when that happens, folks actually dress up, bring their families, come to receive their certificate that they have earned through some various benchmarks that we've identified and talked with them about. And we get 400 people coming to graduation. So that is, I think, all of our favorite night of the year, because we get to celebrate the success of folks who did not go back and have done things like maintain a job for a whole year or maintain contact with their mentor for a certain period of time and so forth. So we couldn't do all of this alone. What's really important for us is our community partners. And we don't expect you to read all those, but we just wanted to give you a sense that, you know, folks in the community typically are set up to help folks, individuals who are involved in the justice system, but they may not have the same kind of background that we have. So we work with the partners to help them understand how best to engage people, how we can get the connection to start before the end of incarceration. How do we help the person who's leaving the jail have a sense that this is the appointment I'm going to and this matters to me. When we started in 1996, there were some agencies who didn't necessarily see the fit when we would pick up the phone and call and say, hey, we're Hampden County Sheriff's Department calling. We've got some folks coming out. Do you want to serve them? But we engaged the conversation and made the partnerships, and we continue having those partnerships. And we now have more than 350 providers. We don't have an MOU with all of them, but with many of them we do. And we have been able to see over time that there's a shared concern across the community that these are really the same people that we serve. And so I'm going to turn it over to Marty, and she's going to talk with you more about how the research has informed what we did.
Good afternoon. I'm Marty Lyman. I've been the research director here at the Hampden County Sheriff's Department for almost 20 years. That in and of itself is kind of a rarity. They're laughing at me because I took my shoes off. I'm going to be honest. So anyway, it's kind of a rarity to even have a research department at a county sheriff's department, but our prior sheriff, Sheriff Michael Ash, saw that we really did need data to drive what we're doing, to really understand what we're doing. When I look at the assess and, what is it, assess and the model, I think there should be another A at the end, which means assess again when you're done, because you should be constantly assessing what you're doing to see if it's actually going in the direction that you want. As Sally said before, and this gets repeated here all the time, reentry begins on day one of incarceration. We do start with a series of assessments, and slides are a little out of order, I think, because that's all right. I'll get to it. But we do a number of assessments. Everyone that comes in here gets a level of service inventory screening, not the full assessment, because once again, we have about over 6,000 people that cycle in and out of here every year, and there's just not enough time to do the full LSI assessment. But we use the screening version, which many of you may know was developed by Andrews and Bonta, and it keys in on the 8 strongest predictors that someone is going to either reoffend and or be a management problem while they're with us. We have found this. We've been doing it since 2001, and we have found it to be highly predictive of recidivism. Based on and then we also do a TCU drug screen, and we do suicide screening, medical screening, PREA screening, and we do a lot of initial screenings. After someone's been with us for approximately 3 weeks, then they have a psychosocial assessment with one of our trained correctional counselors. Based on that, we build an individual service plan that calls for targeted programs that identify any of their identified needs based on those assessments. And we work hard to keep our programs fresh. We're in the process right now of doing a rehaul on some of them. Classification and step down is a huge part of our model. Our philosophy is that we want to move people to the lowest level of security that is safe for the public, for the staff, and for the offender, because some people are not ready to be out and have community interaction too early on in their incarceration. However, we do not hold anyone back simply because they score as having a lot of criminogenic risk factors. If their institutional behavior is appropriate and they are compliant with their individual service plan, they will be considered for step down. And then once someone begins to approach their release date, we are constantly building a release plan. The individual service plan eventually morphs into the release plan, which makes that connection to partner agencies. Now, what does this have to do with data? Well, we are collecting data on all aspects of this model throughout the process, and that allows us to be constantly monitoring what we're doing and seeing if we're getting the desired outcomes or if there are trends that are shifting that we need to react to. So a quick look at, these are just some, you know, I am a researcher, so I love stats. This is kind of who we are. As you can see, we are a highly minority population, young. I think that third bullet is very telling. Even though about half of our people report that they have a high school diploma or equivalent, the actual functioning academic level is a lot lower. This is very important to know, not only for prepping people for release and for employment, but even when we're developing our programs, we have to make sure that, you know, we're meeting people where they are. Not unlike most county jails, you know, about a third of our people meet the criteria for serious mental illness. And a little talk about substance use. Substance use has always been an issue. It is with all jails, but it has really been rising here in Hampden County over the last 10 years. There's a reason for this. This is a heat map that our countywide Hampden County Addiction Task Force has put together using data on fatal and non-fatal overdoses. It's what's called a heat map, and you can see that Hampden County's got a big dark blue blob on it. That's generally the city of Springfield, Chicopee, and Holyoke. Very high rate of overdose. The reason for that, and if we were to superimpose the highway system on there, you would see that Hampden County is right on one of the main drug routes in the Northeast. Interstate 91 comes directly up from New York. From the south, it goes right through New Haven, Hartford, Connecticut, right up through Springfield, and on into Vermont and up towards the Canadian border. We also have the east-west intersection of Interstate 90, also known as the Mass Turnpike, which cuts across the state, actually comes across the country, but ultimately cuts through Massachusetts and goes right on into Boston. So we are a major highway for drug trafficking. So we have a serious issue, and that drives a lot of our incarcerated population. Once again, here's just like I said, this might have been a little bit out of order, but these are just an example of some of the screenings and assessments that we do, and we keep data on all of those. This is an interesting chart. It shows, once again, how we're monitoring what we're doing all the time. Back in 2001, when we first implemented the LSI screening and basically said we're going to use this to drive our service plans, we also told the offender population that from here on in, we're going to assess using an empirically validated screening tool what your needs are, and you are going to be doing programs. They are mandatory. Programs are mandatory for all of our sentenced inmates, and they are highly recommended for pretrial inmates. And we offer, we will hold good time, earned good time, in a bank for pretrial inmates, and if they get sentenced to us, we will grant that good time. So it gives them some incentive to participate. First of all, we found that it was very, very good security policy because it kept people productively occupied so that they had less time to figure out unproductive ways to use their time. But also we found that as we mandated programs, we were able to move more people to lower security that were compliant with their service plan, peaking in 2008, 2009, where almost two-thirds of our inmates were being released from a lower security level, one of those sites that Sally showed you on the earlier slide. As that occurred, we saw a gradual, not a precipitous, but a gradual drop in our one-year recidivism rates. So as more and more people were compliant with their service plans, were taking more responsibility for their actions, were moving to lower security and being able to gradually ease back into the community, their success rates were increasing. What has happened recently, if you look closely at that chart, you'll see that while we had a nice big gap around 2008, 2009, now that gap is slowly beginning to close again. And what is happening, we're finding, is that over the last 10 years, our population has dropped. Our average daily population has declined approximately 30%. Some of that is the result of very good news. Our lower recidivism rate, there are more and more diversion programs out there so that fewer people are being sent to jail. Many, many reasons why our ADP has gone down so much, but unfortunately what we are seeing is that as those numbers decrease, the severity and the chronicity of our offenders' risks and needs has really risen. As that has happened, we have fewer and fewer people that are appropriate for lower security, and as that we have fewer people getting out to lower security, we're finding that our one-year recidivism rate is slowly beginning to tick up again. As this has been happening and the percentage of lower offenders in lower security has declined, we've not only seen our recidivism go up, but what we've had to do is refocus our programs, particularly in medium security, because the group of people, both men and women, that are finishing their whole incarceration behind the wall, we've had to really take a look at what their needs really are. At the time that we were really seeing so many people moving out to lower security, we were able to, we do have a substance abuse treatment unit within the wall. We also have a complete substance use treatment facility out at minimum security in the city of Springfield. We have a lot of treatment for substance use, but so we were able to let people avail themselves of that and then move on to more skills-based programs like, job skills and that sort of thing. What we're finding now is that the people that are coming to jail are not ready for those skills-based programs for a lot longer. They need more cognitive behavioral therapy. They need more, thinking skills. We really need to step back and focus more on, those more basic, the beliefs, the cognitions, the distorted thinking, all of those things that support the criminal lifestyle. So we've had to refocus a lot of our programs, particularly in the medium security, in order to address those issues before we move on to the more higher level skills-based programs. And I guess what I want to say here is that all of this is happening because we have data collection and we're able to, monitor this constantly. I just want to quickly point out a few initiatives we have. A lot of diversion with our probation, parole, and community corrections. What are we pointing at here? Specialty courts. We were kind of late to the party with specialty courts here in Western Mass, but they're finally getting here. Because we have room in our facility, we were able to open up a unit to take civil commitments for substance use disorder among men, offering treatment resources that previously you had to commit a crime and get incarcerated in order to avail yourself of. Now we're able to offer it to people on civil commitments. And we're also looking, are we running out of time, Sally?
Yeah,
okay.
One more minute. Yeah.
One more minute, okay. Sally talked about the regional partnerships we have. We just got a $1.1 million grant with our three neighboring counties to work with high-risk youth. We are opening in July a youth offender pod to deal with our 18 to 24-year-olds because those are definitely a group that are spending most of their time behind the wall. And we, for many years now, have been doing regional reentry for our people coming back from the state prison system and also from the federal system because geographically there are no state prison facilities out in Western Mass. So we've offered the ability to step down and reenter for people that are coming back to this area from the state or the federal prison system. And these are our results. This is what we've seen. Our 1 and 3 year recidivism. We've been tracking recidivism since 2000, so we have quite a bit of data to avail ourselves of, not just the actual recidivism rates, but we try to slice and dice it as many ways as we can, looking at demographics and offense types and locations and assessment results and as many different things as we can to try to put that puzzle together trying to explain why some people reoffend and others do not. And I guess we're up against a hard clock, right?
Yeah, so we're ready to go to questions.
Okay, thank you very much. Again, this is Melissa Neal, and I will be leading us through questions. As I said earlier, please look at the right side of your screen, the right lower side of your screen. You should see a Q&A portal, and there we really welcome you to submit as many questions as you would like to the entire panel, as we would like to walk through questions. If you have questions for a specific panelist, that's fine as well. So we will just get started with a couple of questions we see. So one person asked, and this will go to all of our presenters, from all of the various needs I see of someone released, it is curious to me that I don't see a need for legal services being mentioned. Is that extremely low on the needs list?
You have a lot of people coming in asking?
Well, this is Sally. I'll give my perspective. We do some amount of supporting folks to go back and resolve legal matters. I think our local public counsel services must just do a really good job. When people are out and trying their best, but still they say there's been an identity theft issue, that's one pernicious one.
With Corey.
And a good bit of work with Corey, helping people, we do coach people to do what they need to do to seal their Corey, or to, we work with our job search folks around what is and is not okay in Massachusetts for an employer to ask. So those are some of the things that we do. I wouldn't say it has been high in volume, and it's not on the most weeks the most acute thing that's happening.
Ross or Travis, do you have anything you want to add to that?
This is Travis. I do not.
Yeah, this is Ross. I don't either. That's kind of beyond the scope of our jail mental health services.
Okay. All right, so this was answered by Ross in writing, but I also wanted to give the other panelists an opportunity to respond. One person asked, how do you handle housing needs of a person being released, particularly those who are sex offenders? And again, this is to all of our panelists.
So this is Sally. I could answer Hampden County's perspective on that housing needs, particularly with respect to people with sex offense history. We handle that with a tremendous amount of patience and persistence. It's a delicate issue for all communities. We do have a regional task force to end homelessness that has a specific sub-working group for people with sex offense history. The general public generally, the general public doesn't always have an appreciation for the fact that a stable place to live is a protective factor. Folks are very likely to think, just not in my backyard. But if you talk to any of the local police in your area, especially the ones who track the sex offender registry requirements, they'll say, hey, I'd rather know where the guy is, and we would too. So we make it our business to know the neighborhoods, the landlords, the programs, and there's never enough, so we stay really patient and really persistent. I don't know if that answers your question, but it's what comes to my mind from Western Mass.
Yeah, and this is Ross. Yeah, it's a huge issue with all the different rules and laws and that type of thing. We do have in my response, you can only, type so many characters. So we do, if we can partner with parole probation, they have access to some funding for some programs that meet that need. We also have some adult foster care homes that sometimes we utilize that are more in a rural setting. But there is not a one-size-fits-all answer to that, and that's one of our hardest people, obviously, to place.
And the only thing that I'm going to add to that is, and it's kind of iterating some of this, is it requires relationships, collaboration, and coordination. You have to have some creativity. Like Ross said, perhaps you're looking at housing people in more rural areas that, aren't within certain foot restrictions of schools and daycares and other places like that. But it's going to require a great deal of collaboration between behavioral health, parole, probation, landlords, other providers. And again, there's no cookie-cutter approach to this. This is one of, if not the most difficult population of individuals to secure housing for.
We're all nodding our head in Massachusetts to those comments. Thank you.
All right, we've had a couple of questions come up about criminal thinking or criminogenic risk factors. One person asked, what curriculum do you recommend to address criminal thinking?
Well, this is Ross from Kent County, and so this is in our jail mental health pod. We're really doing more CBT type programming there, but in our other addictions reentry programs, we do, some of that was actually formed with a Second Chance Act grant. We use a combination of a number of things, but we use Thinking for a Change with both our men and our women. And then, although this doesn't necessarily address, it addresses criminogenic risk factors, but we also use Seeking Safety, especially in our women's pod. And then we have a Hazelden co-occurring CBD. I'm saying that wrong, but program that we use as well.
This is Marty in Hampden County. We've also been using Thinking for Change. We particularly implemented that in the last year with a lot of our young men who are behind the wall here in the medium security facility. We also use some of the curricula that are available through the TCU, Texas Christian University's Institute for Behavioral Research. They have a lot of very good programs that are well validated. Most of them were developed with SAMHSA money, so they are free, which for correctional facilities is very important. But we've used a number of, there's one very simple little program in there called Unlock Your Thinking, Open Your Mind, which is a great starter program. Yep. That kind of gets people thinking about their distorted thinking patterns. We've used moral recognition therapy. Let's see. The victim impact. We're doing recovery roadmaps. Has been very good. Dialectical thinking. Behavior therapy. Yeah. So we've run the whole gamut.
Any other comments in response to that?
No, this is Travis. That's a very, very good laundry list, and I don't have any to add to that.
Okay, thank you. Continuing on that theme, someone asked, specific to sex offenders, how do your programs address the criminogenic needs that are specific to this population? Additionally, how do you help them with the collateral consequences of being on the registry, which can greatly hinder reentry?
So again, Melissa, are we talking about a sex offender population here?
Yes, that's what the question seems to indicate.
Okay.
Well, this is Sally. Again, somebody mentioned it, one of the toughest populations to serve. Also, a pathway in life that's very isolating. And so our case managers' connections and the mentors' connections with the men and women who have sex offense history is very, very important. We were delighted about 2-3 years ago when we had a dynamic case manager working with that group of people, Madeline Fernandez, and she said, hey, let's do a support group, not as an ability to meet a stipulation from the court, not as treatment, but just a place where men could come. We use the Good Lives model as a loose guide map for delivering that program. But every Thursday morning we have about a dozen men who come in not to meet any requirement or whatsoever, but to have a place where they can feel like they belong, like they can have the discussions that they need to have, and frankly, to hold each other accountable and to keep each other in a healthy thinking way of mind. So we are glad that they were willing to do that, and we think it's a result of the overall pretty robust engagement of saying to every person we meet, we're willing to keep working with you, and we are invested in your success. We want to protect that investment.
All right, thank you. Another question came through. We know that family social support is an important component of successful reintegration. Please explain ways your programs involve the family or provide them with assistance or services when welcoming a loved one back into the home. So again, that's about. Oh, go ahead.
The family connection. Marty's pointing our attention into the direction of our Mill Street facility, the Recovery and Wellness Center. They have a family day on a regular basis, as well as while their person is serving time, there's just a meeting for family members of those who suffer with substance use disorder. Those kinds of events that help the family members understand what the person is going through and what the needs may be when they come out are very important. At the Reentry Center, we often find people at a place that I would say is pretty threadbare socially. So when I go by the intake office and I see someone with, a spouse or an auntie or their kids with them, it's a little unusual, and we go by, we make sure and say, hey, you're welcome, and, we try to encourage that support. But many of those bridges have been burnt, and it's not until there's quite a while of the person really walking the walk before the family members believe them. I would say the high point for us is probably graduation, when the person has been out for usually a year or a couple of years and has been doing something right and something good. That's a really beautiful moment. And so I guess I'm thinking that we start it early when we can. It takes a long time, and it might not be till quite a while after release that the family may actually be ready to reconnect and be part of that process.
Okay, Ross or Travis, any other comments on family social support?
No, I don't really have that because our handoff is really to the community agencies, and they typically would be doing that type of any type of outreach to the families.
And since I'm not directly working with a program, I don't have any comments to add to that.
Okay, thank you. All right, so we are getting close to the end of our presentation, so this will be the last question. We had someone state that they are in a very rural West Texas jurisdiction, small jails, small budgets, and long distances to inpatient psychiatric services. And so, is there any recommendation or any advice from the panelists or presenters to this, our listeners who are coming from these really small jurisdictions that may not have a lot of resources to work with in terms of creating reentry services?
This is Travis. My advice would be is if you have or can develop a relationship with and I'm going to use a generic term, your regional behavioral health authority, that may be working with providers who will come into rural areas to help with that reentry planning. Even though I work for Policy Research Associates, which is based out of New York, I live in Nebraska, and do have the opportunity to go into about 15 rural jails here in the southeast corner of Nebraska. And those jails, those sheriffs have all developed relationships with the Regional Behavioral Health Authority to have staff like mobile crisis response and case managers and peer specialists come into the jails to assist with reentry planning or even some jail-based crisis intervention when it's needed.
Then just to add to what Travis is talking about, I know I don't have direct experience because Kent County's jail is a very, very large jail, and so it's pretty easy to, it's a good economy of scale. I know that for some of the more rural, and we're doing this as well because we can't be in all places in one time, we use some telemedicine type, that way you don't have to be you could be located 60, 100 miles away, and you could do reentry planning so that you don't have all that travel time because you could waste a half day going from jail to jail. And
Thank you. Any other comments in response to that question? Okay, hearing none. All right, and I think that another person responded also to look into technology to address services needed in rural areas. So additional materials for you all to take away from this webinar, you should see a box popping up on your screen. It says file transfer, and there should be some files popping up in that box. The first being the guidelines that Travis went over during his presentation, as well as the Gaines Reentry Checklist that he mentioned and others have mentioned during their presentations. We also are including a certificate of webinar attendance. If you do need to submit proof of participation in this webinar, you can download this and add your name in and submit it as proof of your participation in this webinar. So those are the three documents you should see available. Just click on the file name and the download button will then light up in a gray color, and then you should be able to hit the download button and it will then download directly to your computer. Also, please, if you haven't done so already, sign up for the Gaines Center's listserv. We will have the recording of this webinar as well as the slides sent out to this audience. So if you are on our listserv, you should get the notification about when this webinar is available for viewing and when the slides are available. And finally, if you have any other questions or would like to contact the Gaines Center directly for additional information or phone-based consultation, our information is at the bottom of the screen. Feel free to reach out to us at any time if you would like to get additional support or information about improving services to individuals who are reentering your community and are experiencing a mental or substance use disorder. So thank you so much for joining us, and we will bring this webinar to a close. Thank you so much. Have a great afternoon.